This is the Get Healthy 360 podcast, where we discuss topics related to your physical, mental, psychological, and spiritual health. Your host is Dr. Kris Ferguson, board certified in anesthesiology and pain management. This podcast is for informational purposes only, and you should consult your primary healthcare provider before making any decisions related to your health. And here's your host, Dr. Kris Ferguson.
So hello, we have Dr. Laurie Boore-Clor. She is a geriatric psychiatrist. She works at the VA in Ann Arbor. So that means that she went through undergrad, got top scores, got into medical school, subspecialized in geriatric psychiatry. How long did that specialized training take?
It was 1 extra year for a fellowship.
Okay, so and then psychiatry is 4 years.
Yes.
So you've been in training to do what you do for how long?
13 years.
13 years. So you're very good at what you do. So can you tell me and everyone a little bit about what geriatric psychiatry specifically is?
Sure. First, I want to thank you for having me. Geriatric psychiatry is a subspecialty of psychiatry where we do a lot of different things. First is we take care of people who have had mental illness and they are lucky enough to age, but they get medically complicated too. So we'll take care of their mental illness and watch out for their medical complications and their medications. We'll also get new and progressing cases of dementia, each of the different types of dementias, because dementia is kind of an umbrella term like cancer, and underneath that there are several types of them, and they're all treated differently, so we want to make sure that we're doing the right thing. So we'll get dementias with behavioral disturbances, patients that have been perfectly healthy their whole life, who suddenly develop anxiety, depression, bipolar disorder, people with chronic grief or new grief from loss of a loved one.
So can you clarify exactly what dementia is? I know it's a very vague term, at least in my mind.
It is because it's an umbrella term. Dementia is a condition in which their memory and executive function begins to deteriorate. And you usually start seeing that with when they forget names. So anomia, forget how to do things, apraxia. And then it can progress.
So what is apraxia?
Forgetting how to do things.
Okay. So they forget people's names. They just are starting to forget how to do things.
Mm-hmm. And then depending on which sort of dementia is which you get. So the most common type of dementia that most people think of is Alzheimer's, where it starts like that. It's very gradual. People will look back 6 months to a year and they'll say, oh, you know what? Mom was saying the wrong words for different things. She was forgetting the name of that. She forgot her grandson's name. And now we see she's not cooking. She's forgetting to turn the burners off on the stove. She goes to the store and she forgets what she's buying. She gets lost on the way there, disappears for 4 hours, has no idea where she's been. And then Alzheimer's can progress to where they're bedbound, and that's usually the end stages. The other dementias are different. Like vascular dementia is a stepwise progression. So people will go along fine for their life and then all of a sudden have a cardiovascular event, like a stroke or a heart attack, and they'll say they can't remember how to do things. They physically can't do something, so that's where apraxia gets a little dicey. It's because, well, they should be able to do that, but they physically are not able to because of the complications of their stroke. But then they forget, again, how to do things, what names are, where things are, to take their medications, basic life skills, can't drive because their memory and their reaction time has gone way down. There's alcohol dementia, which after many heavy years of drinking, people get dementia that looks like pretty much like Alzheimer's. The farther that progresses, you get behavioral disturbances too. You can get behavioral disturbances with all of the dementias. Parkinson's dementia happens almost any time, 5 years after Parkinson's diagnosis to 25 years later. Sometimes that'll turn into Lewy body dementia, which is one that has visual hallucinations where people are seeing things that aren't there. Their memory is poor. They're making the wrong choices and they're impulsive. Their personality has changed, and that one's a really complicated one. Then there is frontotemporal dementia, which happens younger, and people, the biggest key with that one is people's personalities change because their frontal lobes are degrading. So you have the person who's the nicest guy and then clocks his granddaughter and throws her across the room. And that's usually something violent like that triggers people to say, what's going on here?
What would be a trigger for someone to say my elderly relative or my parent or someone I know is getting older? Well, first, how old are people typically when they start having signs of dementia?
Usually the straight up ones, like Alzheimer's, is in their 60s, so about 65, late 60s. Frontotemporal is earlier, so early 50s, mid 50s. Early onset Alzheimer's can also happen then too. Parkinson's is a little bit later, like early 70s, late 70s. And then alcohol dementia can pretty much happen any time because of the way that alcohol changes the brain.
So would you say that there's any safe, so just as a side note, is there any safe amount of alcohol you think someone can take, or what amount of alcohol is going to cause alcoholic dementia?
It's the guys that are, well, it depends. It depends on the person because some people can't handle more than a glass a day and that'll build up over time. Some people drink a pint a day and are perfectly fine. So there's really no direct correlation between that. But from what I've seen with my work at the VA, it's the guys, and it's usually the guys because most of my patients are men, that are drinking a 6-pack a day or more for years and years. And they skip all of the regular complications like cirrhosis and esophageal varices and end up with dementia instead.
How many of the people that you see also have PTSD?
Surprisingly not that many. I would say about half to 60%, and of those, half is civilian PTSD and the other half is military PTSD. My population is a little skewed because I specialize in the Vietnam vets and older, and some guys have gone to Vietnam and have no issues whatsoever with PTSD. Some people had civilian car accidents, or one guy I know got carjacked in his own driveway, and he has PTSD from that.
So do you treat the PTSD, or does someone else treat that?
We share it. We have a fantastic PTSD team in our facility, and they will do the prolonged exposure therapy and
what is the prolonged exposure therapy?
Prolonged exposure therapy is kind of going through the event over and over and over to process it, to wear it down, to normalize it, to make it not so prevalent. They'll do that, and they'll do cognitive restructuring.
Which is what?
A lot of people have a lot of guilt about what happened. So they'll say, well, I killed somebody. Well, that's war. That's what happens in war. And they're not trying to make it right. They're trying to kind of spin it around so it's not haunting them every day. So they'll do those types of therapy mostly. But then they'll do general stuff like cognitive behavioral therapy where they work on the thoughts and the feelings that come from those events. And then the rest of the psychiatrists will take care of the medications for that. So we'll work as a team.
So how effective is that PTSD therapy?
It depends on how much the patient puts into it, to be honest. If I have patients that have come back from the therapy on that and have amazingly done so much better. I had a guy who thought he was hopeless after 40 years of PTSD from Vietnam, and now he can go out. He can go to restaurants. He can be around fireworks. It'll still get him every now and then, but he knows there are different skills he can use to get through those times. And then I have people who are drinking or using marijuana or just not coping well, don't have social supports or finances, and they don't tend to do as well as the others do.
How uniform is the treatment for PTSD in the VA? Because I've worked with PTSD veterans in several VA systems, but it seems to be not a uniform treatment throughout the whole system.
No, because we want to specialize it for the patient.
No, I mean just the amount of access to care in individual VAs.
It does depend on the VA. Each VA is its own entity. So it sounds like we all do the same thing, but we don't, because we have enough support and we have enough therapists, social workers, psychologists, and psychiatrists in ours. But some VAs don't have even a psychologist. So they'll go to like a veteran center where they have a social worker. It's not structured therapy. It's more supportive. The psychologists and the social workers can definitely speak better to that than I can.
Oh.
But it really does vary center to center.
Okay. Do you know if there are any sort of steps being taken to unify the VA so that the same services are offered at all the VAs?
It depends on the staffing. It's really, all of the resources are there. The VA has a national database. They have a national website. They have a national PTSD center. It's just finding the people to do the work.
So can veterans go from between different VAs? Like, say if they knew that, say, Ann Arbor, where you work, has a phenomenal, because it sounds like you have a great PTSD program and dementia program. Can someone from another part of the country go to your center and get treated?
It's hard because we don't have a dedicated physical location for it. We just have regular outpatient care. So they would come for their therapy appointment an hour a week for 12 to 16 weeks. where they're group an hour for 12 to 16 weeks there. Some places, there are centers across the country where they can go for like a residential program. Battle Creek has one, and it's hard to get into.
What has one?
The Battle Creek VA on the west side of Michigan.
Okay. They
have one, but it's so hard to get into because they have limited staff, limited amount of people that can get in, and a high proportion of people who would benefit and are on the waiting list to get in.
Sure. Do you know how long the wait list would be?
It's so hard.
Okay.
It's so hard. Yeah, we don't know.
Okay. And then, so how does the PTSD affect dementia? Or I don't really get the interplay of how you would treat both, because it seems like they'd both be very challenging.
They are both very challenging. PTSD over the long term is a chronic disease, and it's a chronic inflammation. So like any chronic inflammatory disorder, the inflammatory markers are going around destroying what they're not supposed to touch. So they'll work on their heart, and now you're finding inflammation in the brain for like depression. So with PTSD being that high, with the cortisol levels running that high for so long, it starts to degrade the brain. And they don't have, like with dementia, it's a cleanup process problem. Dementia, there's all this, like, so you know how the cells clean themselves and they have to get rid of the waste? With regular dementia, you can't get rid of the waste. With a high stress situation for 40 years, you're constantly generating waste. And then when Alzheimer's or other dementias come in, you can't clear it out. A lot of people with PTSD cope with alcohol. So then you add that layer on there too.
So I don't know much about dementia, and I know just a touch about PTSD. So can you explain to me in very simple terms, or go over explain to me let's talk about the dementia, then we can talk about PTSD. Just go through that cleanup process that is causing the dementia.
Okay, in dementia you have what they call tau proteins, and then you have microtubules. And microtubules are like railroads, where you load stuff onto the railroad and to the trains, and you take them down to the processing center to get it out of the cell. In dementia, the railroads start breaking down, so you can load up the trains all you want, but you can't get the waste out of the cell, so it starts building up.
Okay.
With the stress from the PTSD, it's just breaking down everything it can get its hands on. So there's more and more waste for the trains, but there's no trains and no railroad tracks to take it out of the cell.
So the two together are almost worse than one individual disease.
It's unfortunate, yeah, because what happens is over time, people with PTSD can tell the difference between reality, their flashbacks, and memories. When you get down the road for having dementia for a while, you don't have that capacity to tell memories from reality anymore. So people can watch TV and assume that they're watching a TV is happening right in their living room. Or they'll remember something and they'll think that memory is happening right now. And they'll act out, or they'll hit somebody, or they'll try to run away. Or they just suffer because they can't verbally tell you what's going on. So they'll get agitated and they'll pace. And it's really horrible to watch it because you know they're suffering. So
it's interesting that if you can talk a little bit more then about that chronic inflammation and if there are any inflammatory markers for PTSD.
You know, I'm really not the one to talk about that because I don't know off the top of my head. I just read that interleukin-6 was implicated in postpartum depression. Mm-hmm. So I put my numbers on the interleukins. So like C-reactive protein is higher too. It's just in chronic inflammatory diseases. They see some of those markers in depression as well. But then too, people with PTSD will have hypertension, so they'll have high blood pressure, they'll have high cholesterol. So all of those markers that go along with the cardiac inflammation will go up as well.
So have you seen any physical treatments work well for PTSD? So there's this procedure called a stellate ganglion block where you can go in and block some nerves in the neck that activate the sympathetic system. So there's the fight or flight system where you have the sympathetic system, the parasympathetic system. So by blocking that stress response, theoretically it should help with PTSD.
That makes sense. I've never seen it though.
But the research is very weak on it. And there's some theories why it's weak, but I didn't know if you had any thoughts on that.
To be honest, we would never have done it at our VA. We don't have procedures like that. We stick with medications and therapy.
So so with the dementia, so I guess you would have to treat specific dementias with specific dementias would require specific medication treatment.
Very much so, yes. Mm-hmm.
So can you go ahead?
Sorry, you first.
Oh, so what, can you discuss like the different dementias and some of the medications that you would use for them?
The first thing we want to do, though, is make sure it's not dementia. Because I'll get a lot of cases upstairs. I'm upstairs. I always say upstairs. I'll get a lot of cases in my office upstairs where people are starting to show memory problems, or they're forgetting their words, or they're concerned about something. So their primary care doctors will do what they can do and then send them up to me. So what they've done already is they usually have done a CBC to make sure that they don't have anemia. They've done comprehensive panel to make sure like their kidneys are functioning well. They check their thyroid to make sure that they don't have hypothyroidism, but hyperthyroidism can cause memory problems too. In the elderly, hyperthyroidism can cause depression in the elderly, which is usually not how it is in the younger people. So we'll have to make sure that's okay. We look at vitamin deficiencies, B12, folate, vitamin D, because that'll give you a little bit of a memory problem. So it may not fix the problem when we replenish or fix the medical problems that are already happening, but it's kind of releasing the burden a little bit. But I will say we have to test for syphilis, and I will tell you this story, is I read a JAMA article where it said it wasn't really cost effective to test people for syphilis when they come in for a dementia workup. And I said, that's against my training. I said, I can't believe they said this. And then I had a guy in my office the next day, and I said, well, I should order an RPR to test for syphilis many years ago that he would have had then, but is now showing up as his memory. I said, well, JAMA said it's not cost effective. I said, no. I said, I'm going to do it. And I caught my first case of neurosyphilis. He went to infectious disease, got treated, and he's been fine ever since. So that's what we want to watch out for. I had another gentleman whose folate was really low. We replenished it. He feels 1,000,000 times better. So that's the kind of stuff we're looking for, is to make sure that it's not something we can fix easily.
Any benefit from supplementing vitamin D for dementia?
If it's low, you want to, because it will affect their memory.
Sure. So is that any sort of dementia, or I guess that's dementia caused by a specific medical abnormality? Mm-hmm.
Yeah, we'll call it dementia due to a reversible factor. So that's why we want to rule out all of the reversible ones that we can. Sometimes I actually had a guy who had prostate cancer, and he had his prostate removed, and he came in for memory problems. And I said, well, it didn't sound classic dementia, like very stepwise fashion, very orderly. It sounded very scattered. I got a brain scan and a PSA. His PSA was like 40, and he had mets to the brain. And I was like, well, we're done. That's not dementia. So it kind of is. It's memory problems related to metastatic prostate cancer. It was so sad.
So then how would you treat, like Alzheimer's dementia?
Okay. The first thing we do is we look at what we're treating. Are we treating their memory, or are we treating behavior? If it's their memory, we'll try to do, it's like simple things. Geriatric psychiatrists and geriatricians in general are the first to actually step away from medications, because we'll look at all of their medications, make sure it's not a drug interaction, make sure it's not delirium, make sure they're not doing something on the side like alcohol or marijuana. So we'll do all these rule outs first. So when we actually go in to treat it, we'll ask what do they want. Some people will ask for donepezil, which is Aricept, or memantine, which is Namenda. They're okay. The research doesn't really support them, because when they first came out with donepezil, they said, yes, people who take this improve on testing. Well, when you look at the testing, it was a 122-point scale, and the people that took donepezil scored 3 points higher. And it was like, really? For 3 points?
Sure.
So we're going to run the risk of all the side effects with that?
So what are the side effects of those two medications then?
Well, donepezil is an acetylcholinesterase inhibitor, so it'll give you those effects. It'll make you nauseous, diarrhea, heart rate will go up. People feel jittery. Some people just don't like it. Some people will get night terrors, and they'll wake up screaming. It's like they had the most horrible nightmare, but they can't remember what happened. So if that happens, but they feel okay with it, otherwise we just move the dose to the morning and they're fine.
And what medication was that one?
Donepezil.
Namenda does.
Mm-hmm.
And then Namenda,
which is memantine, doesn't really have any horrible side effects until you have kidney damage. Memantine does not damage the kidneys, but if the kidneys are damaged, it will process it slower. So the levels will build up and people will feel worse. They'll feel more cloudy. They'll feel their memory's worse. They feel sluggish. They can't get things done. They can't put two words together. And then we look at their creatinine function, which either kidneys are getting hurt from high blood pressure, diabetes, something else, some other medication maybe. And then we'll get rid of it. Some people take both of them and they feel fine with both of them, But what you're doing with the medication is you're buying time. So you buy 6 months. If you stop that medication, they will revert to where they would have been anyway. But you buy 6 months, and that means you buy 6 months out of the nursing home. So that's 6 months of finances that you've saved, 6 months of just the unfriendliness of some nursing homes, just 6 months of finding the right place for somebody. But that's the most of it. They came out with a study if a patient took memantine with vitamin E, it actually lowered caregiver stress. So the patient didn't feel any different, but the caregivers, for some reason, were less stressed about taking care of their loved one.
Because the patient was taking vitamin E?
Mm-hmm. With memantine. Mm-hmm.
Do you have any theories as to why vitamin E would help?
No idea. They've been saying vitamin E helps ward off dementia for years, but the research lately has shown no, it doesn't, and it can increase bleeding risk in those that are taking blood thinners. So we just try to stay away from it. If they're taking it just as a regular supplement, okay, fine, but high dose, no, we just tell people not to do that. But we really don't know. It's supposed to make the membranes of the cells easier to work with, like more flexible, so maybe you can get more junk out instead of keeping all of it in the cell. But we don't really know yet.
So is there any research, or what is the best recommendation right now to help prevent, say, Alzheimer's dementia?
Physical activity. Regular physical activity, regular exercise, very modest alcohol, good diet, anything you can do to lower the inflammation in your system, lower cardiovascular risk factors, because vascular dementia can overlap with all of these, and they can all eventually overlap together. But if you can prevent the little things from happening, again, you're releasing part of the burden that's already been put on. That's the best way to do it.
So do you have a specific routine or supplements or exercise routines that you do?
I swim and I walk on a regular basis. I also have to do physical therapy exercises for old sports injuries that are very yoga-based. So I'll do those 2 or 3 times a week.
Any specific diet or supplements that you would take?
That I take? No, I just take my multivitamins.
Okay.
Personally.
And then, well, I'm always curious what people do. It's one thing when you see a lot of research, but it's always interesting to see what people actually do in their personal life versus what they recommend. Like, it seems like there are a lot of pulmonologists specifically that will smoke, and then they deal with pulmonologists. I don't know why that specialty tends to smoke a lot. What about the other dementias? If you want to comment on those as far as treatment.
Sure. Those I'll take them bit by bit. So vascular dementia is one of more prevention, kind of like for when you have a stroke. Neurologists talk about secondary prevention so you don't have another one. It's kind of the same thing. We want to prevent that next heart attack. We want to prevent that next stroke that knocks them down. So again, we'll try them to get exercise, lower their blood pressure, stay on top of their diabetes. I have had medical students comment that I have not talked about psychiatry with my patients. I've talked about their diabetes the whole time. And I'm like, well, this is why. I'm trying to prevent something worse from happening. So vascular dementia, people will come in with apathy and motivation, so they don't want to do anything and they don't really care. So what we'll actually treat them with is we'll try sertraline, which is an SSRI for the depressive part, but sometimes they'll end up on sertraline, fluoxetine, which is Prozac, citalopram, Celexa, any of the SSRIs. But if they're kind of feeling a little bit better from it, but really still complaining about apathy, we'll actually give them some Ritalin, methylphenidate. It'll be low dose. It'll be like 2.5 milligrams, 5 milligrams, anywhere up to 20. Children with ADHD take 20 milligrams twice a day, 40 milligrams twice a day. So when we're talking 2.5 milligrams, it's really a sprinkle. So those people will get moving again, and they'll feel better, and it doesn't affect their blood pressure. It doesn't affect their heart rate, because we're talking very low doses. Vascular dementia patients will eventually live long enough to overlap with Alzheimer's. So you'll see a lot of people in their best interest of the patient start donepezil to kind of prevent their memory from getting worse. But it doesn't have any bearing on vascular dementia, because vascular dementia is little teeny strokes all over the brain over time, which isn't what donepezil does. But because they're living long enough, now their brain is changing into an Alzheimer's fashion, then the donepezil will try to kind of come into play and kind of help things. Parkinson's dementia is very complicated. It's heartbreaking because it can transfer into Lewy body dementia. But I have several patients that have.
So what is Lewy body dementia?
Oh, I'll tell you in a second.
Okay.
It's kind of, the neurologists do a really great job of teasing this out, but when it comes to treatment, they turf it to us because of all the medications that we use. But Parkinson's dementia, it's the motor symptoms. You've got the classic tremor, the shuffling gait, the stooped over posture, and they'll progress into dementia like in Alzheimer's patients where they forget things, they forget how to do things. And at some point they may start having visions of things that are in the room that are not supposed to be there. So the first thing we do is we check their Parkinson's medication, Sitimet, which is that carbidopa-levodopa, because if you adjust that too fast or too high, the visual hallucinations and seeing things is the first side effect they'll get. And if that's not the case, then we start looking at a Lewy body picture. And Lewy body dementia is the messiest. It's coming up as the second most common dementia. And for me, it's the most heartbreaking because you have somebody who knows that something's not right, but they can't tell you why. So they'll have executive dysfunction, which means they think they can do higher order tasks like pay their bills, drive, take care of their medications, but they're really screwing it up really bad. So they're doubling up on their medications, not taking them at all, disappearing for 6 hours, their car's all wrecked up and they have no idea what happened. They start getting motor symptoms like the Parkinson's patients, so they don't have that real classic tremor, but they shuffle when they walk. They're kind of stooped over. Their face doesn't really have that animation that it used to. But when you treat them with Sitimet, like you would with somebody with Parkinson's, they don't respond as well as Parkinson's patients do. So with Parkinson's, it goes in order of motor symptoms first, and then cognitive memory problems next, and then visual hallucinations. With Lewy body dementia, it starts with cognitive problems, and then you kind of start seeing motor and visual hallucinations within a very short time period of each other. So when I'm getting the history from my patients or their family on Lewy body, we're all sitting there trying to put it all together. And for me, what I've learned now is the most unscientific way to do it, but if law enforcement has been involved, it's Lewy body, because the law enforcement officers have brought this person home. They've been called out to the house because they want to shoot the washing machine because there's somebody in the washing machine. People are stealing from them, and here's all the proof. Alzheimer's patients will do that too. They'll misplace something and then assume somebody's been stealing, so they'll call the police, but usually Alzheimer's is not as messy as Lewy body. And Lewy body is really tough to treat because we'll use atypical antipsychotics like Seroquel, which is quetiapine, or risperidone, which is Risperdal, very low doses to manage the behaviors and the agitation that come with them. But with Lewy body dementia, as with Parkinson's, even those small doses can make symptoms worse. So sometimes that's how we actually end up diagnosing Lewy body is a behavioral disturbance has happened. We need to take action because the risks and the benefits, you have to have that whole discussion. The benefits are outweighing the risk right now, and we need to do something. And then they get worse. So they're more agitated, they get locked up, and their motor system is stiff and they're hard to move. And that's usually how you make the diagnosis.
So then all of these medications also have side effects I think you should look out for. So correct me if I'm wrong. I think when people are taking carbidopa, levodopa, the treatment for Parkinson's, sometimes they can get these manic episodes where they will be sexually promiscuous. They will go gamble. It's almost like they're having a manic episode.
Mm-hmm. Yeah, that's very true. They just dial a dose down or find another agent. And it's hard to find another agent because the carbidopa-levodopa is exactly what your brain is needing at the time. And they just have to tinker with the dose or add another medication on. I can't remember which one to kind of offset that, but you're absolutely right. That will happen. The other thing too with that is if the dose is too high, they'll actually look like they have chorea. So which is, they have all those trunk movements where they kind of wiggle and dance on their seat and their arms are flying around. You're like, what is going on here? Again, they dial down the dose and it goes away. I had a gentleman that loved it. He's like, I like this high dose because I can get all the stuff done, I can move. And he's just wiggling and writhing in his seat, and he's like, how do you even sit still?
If someone has a family member or someone that's close to them that is getting older, how do you differentiate between them just getting older and they're just a little bit crotchety versus there's some sort of pathologic process going on?
Well, sometimes people write off mild cognitive impairment as normal aging, and mild cognitive impairment can lead you into people will say it's like early Alzheimer's, and that's what you want to make sure it's not a distinction. But sometimes people, I've learned, especially with my veterans, they're just done. They're done trying to help people because they've been burnt by so many people. They are done trying to go out because these kids on the roads can't drive these days. They're all texting on their phone. So they kind of get fed up and they stay in the house. But as long as they're doing something, I'm kind of okay with that because are they going to church? Are they going for walks? Are they meeting up with their families? if they're doing stuff like that, okay, fine. Are they isolating themselves? Are they drinking? Are they watching TV all day? Have we not seen them for their appointments? Is their health getting worse? Then that's not normal. A psychiatry will say there's a problem when it is interfering with their daily life. So some people, like guys who retire and watch TV all day, it's a hobby. It's what they want to do. They haven't watched TV in 30 years because they've been working all day. That's okay. That's fine. That's a hobby. It's not destroying their life. It's the ones that aren't leaving the house, aren't taking care of themselves, haven't showered, haven't eaten, haven't taken their medications. That's where the problems come in.
Any advice for someone if they have this older person in their life that they care about, but they think they may have some sort of dementia process? They're not really sure what's causing it, but they just think that there's something wrong. What would be the next step?
The next step is to talk with them as lovingly and non-judgmentally as you can. A lot of people have insight, so they know something's not right, but they can't tell you what. Or some of them, I just can't do this anymore. I can't keep my head together. It's really hard because people are so different. So some people are very defensive. Some people are very willing to talk about things or why they're different or why they're not feeling right. So if you can have that conversation with a loved one, usually the next step is, can I go to the doctor with you? Can we make sure that you're taken care of? So I have some people that I have a whole room full. They brought their spouse, they brought their kids, they brought their grandkids. And then I've got other people where I'm trying to find somebody I can talk to. That this is not right, this is harmful, something bad's going to happen. And they either have no one or they won't let anybody talk to them. But if you have somebody who is open and willing, the next step is, we're here to support you. Let us go to the doctor together. Let's figure this out.
So I know I want to be respectful of your time. So any closing thoughts or advice for anyone other than what you've just said?
Well, just a couple things. Non-pharmacological methods are the best ways to handle dementia with behavioral disturbances, like the shooting people in the washing machine and stuff like that. So they have designed a program through the University of Michigan by Dr. Helen Kales. It's called the DICE approach, D-I-C-E. So they're going to be rolling that out to give caregivers training, which would be great because caregiver stress is a huge part of what we do as well. Another thing is not be afraid of medications. Because
so wait, can you talk a little bit more about the DICE training?
Yeah, so Dr. Kales kind of invented it from all the work she's done as a geriatric psychiatrist, because a lot of the medication research that she has done has shown that you don't want to use typical medications with treating dementia because of the side effects. Because like benzodiazepines like Ativan and Xanax will make their memory worse. They're a risk for respiratory depression, so it slows down their breathing. They make them fall and break their hip. You know how old people are when they fall and break a hip, they end up in the nursing home, and that's the end. So based on her research, she has come up with this method of saying, okay, let's describe what's happening here. Let's investigate the cause behind it. Let's get together and come up with a plan to see what we can do to kind of like figure out what's going on. They call it create a plan, and then evaluate, step back, and is this working? Because sometimes it's that simple. And so she's come up with this program, and they're rolling it out in steps. And it's hard for me to say because I'm at the VA, I'm not at the university. But they will come up with a manual, and they will roll out the manual to help other people get the training that they need.
Do you know when that DICE training will be coming out?
I want to say in the next year. I haven't heard back from the people I emailed yet. So
okay, sure.
I'm going to say that next year. But they're really hot on it because of all the side effect medication research that's coming out.
Okay.
But then that's my flip side. It's contradictory. Is don't be afraid of the medication because it does work. I have people who do great on it. It's very happy that they have it. They take low doses. We eventually see if they still need it. And it's been life-changing for the caregivers, too, because now they're not constantly fighting with somebody. And their loved one feels good. They're willing to go out and do things with them.
Fantastic. Well, Laurie, Dr. Boore-Clor, thank you so much for your time and great information.
Well, thank you for having me, Dr. Ferguson. I'll be back if you need me.
I'm sure I will have you back. Thanks so much.
Thank you.
Thank you for listening. If you enjoyed this podcast, please subscribe and visit the Get Healthy 360 Facebook page. We are always looking for feedback and new story ideas. Thanks again, and see you next time.